So the central research question for this policy brief was how does the Iranian cultural legal nexus affect the quality of life of people who have or wish to seek gender-affirming care? By a cultural legal nexus, we mean how the laws which are influenced by Iran's culture affect health outcomes for specifically transgender individuals. We will also be talking about the Iranian healthcare system in general to get a general view of how gender-affirming care in Iran works. When we talk about gender-affirming care, we mean any services that help a person with gender dysphoria better identify with their gender through trans medical procedures. Specifically, we'll be talking about sex reassignment surgery. But it's important to note that just because someone is seeking gender-affirming care doesn't mean they are seeking invasive sex reassignment surgery. In Iran, being referred to for gender-affirming care means you are required to attain SRS, so that is why we will be treating these terms as interchangeable. The additional questions that we form from that will be how does this affect health outcomes for transgenders in Iran? How is this different from the United States? And finally, policies will be recommended at the end to improve health outcomes in both countries. So just for some background, gender-affirming care was pioneered in the first quarter of 20th century Europe, so like the 1920s, 1930s. And the first sex reassignment surgery is accredited to have happened at the Institute of Sexual Science in Germany of 1931. The Weimar Republic after World War I was very progressive for its time and led the world in psychosexual studies, as well as queer rights. Obviously, this was quickly dismantled under Nazi Germany, but gender-affirming care did not become a practice in the United States until the early 1950s. Later on, this translated into Iran in 1982, when Ayatollah Khomeini took power after the Islamic Revolution. He issued a fatwa, which is basically a legal argument or interpretation of the Quran to be used in the Islamic Justice Court. And this allowed gender-affirming care for, quote, individuals whose faces are inconsistent with their gender. But this has been interpreted in the Islamic jurisprudence to mean the idea of the soul versus medical technology. So in the time of the Quran, medical technology was not available to perform transmedical operations. So they are basically accepting that a gendered soul can be put into a body that does not correlate with the gender they identify as, and medical innovations have been invented to correct that. So it is halal in the Islamic legal code. It's interesting because Iran is the only Islamic country to have SRS practices, and it conducts the highest amount of them in the world. The most surgeries in the world are conducted by Thailand. About the Iranian healthcare system. So some context about the Iranian healthcare system. Iran has a mixed market model similar to the United States. It doesn't have single-payer insurance like in Canada, and it also doesn't have an NHS like in Britain. But healthcare is a constitutional right, and the duty bearer for this human right is the Ministry of Health and Medical Education. So services like vaccination are provided for free through tax dollars, but there is a kind of urban-rural divide. It is much easier to access care in urban areas than in rural areas. That's pretty much true everywhere, but in Iran we really see this effect. So Iran has been approaching universal coverage in recent years with the new primary healthcare system model. This can basically be described as having various control knobs which have deficits and benefits to them in their own ways, and they are adjusted through government policy over time. Something interesting about the Iranian healthcare system is a policy when there is one general practitioner assigned per village called the bachelors, is assigned to every rural community. So every village has its own doctor, basically. So reviewing some of the control knobs, there's organizing, regulation, behavior, financing, and payment. I've written down a benefit and deficit for each of them. The first one is how the primary healthcare system is organized in such a way that there is a wide network of separated components. But a deficit of this is that there's a lack of change along with healthcare needs. So as healthcare needs grow, or there is different healthcare needs which are discovered, the wide network doesn't change with it. It's basically used to dealing with the same situation over and over. For regulation, it has gotten better in health and disease prevention, but there is still a conflict of interest between policymakers and managers. So there are not a lot of proper regulations getting done or regulations that lead to better health outcomes other than disease prevention. And that would be in the form of proper surgery and things like that. As far as behavior goes, this primary healthcare system has brought about closer relationships between constituents and their providers, so between the village people and their doctors, but there is insufficient training in communication skills on behalf of the doctors. It's more seen as an empirical such scientific practice, like a skill to develop, and they're not very good at explaining it to people who don't understand or aren't knowledgeable about medicine. And financing, the primary healthcare system provides free healthcare services. We reviewed that in terms of vaccination and also free medical insurance in some areas. We can translate this to reforms in the United States with the Affordable Care Act. There is government subsidized insurance along with private insurance, but private insurance is still the main insurer. On the downside of this, there is a bit of lack in coordination and financing because all the different components of the wide network are acting pretty much independently. They don't have a unified plan in how they spend money. As far as payment goes, this is mostly referring to doctors that are employed by the government. It is mostly hospitals that provide healthcare services in Iran. So, in that sense, it is more of a public healthcare system which sets wages. This has led to a lack of motivation and a dominance of fee for services because of a lack of incentive. So here are some of the costs and methods of funding for gender affirming care. What we are talking about here is health costs as well as monetary costs. So in Iran, the government clergy will sponsor some surgeries. The church and state in Iran is very different from the United States. They are more interconnected. So some of the donations received by the church are put towards gender affirming care ostensibly on behalf of the government. But transgender Iranians might seek the assistance of private insurance to help pay for their surgeries and care also. It is cheaper for many transgender Europeans to seek care in Iran because the cost is less due to less competition in medical innovation. A body called the Imam Committee provides interest loans to people to seek out gender affirming care and surgeries also. On the downside of this, professionals are undertrained, and this leads to botched surgeries that you still must pay for and go back for the same operation again, and this leads to higher risks of health complications. By contrast, in the United States, it's pretty liberal. Every state except Idaho allows the usage of public insurance or Medicare for gender affirming care. The cost of invasive surgery in the US can range from $40,000 to $60,000 before insurance. After insurance, it's usually brought to below $7,000. But that's compared to $95 to just $3,000 in Iran before insurance. But as you can see here with the 90 million real I have written down, Iran suffers from massive inflation, and that could translate to lower real wages and an inability to pay for surgery. As far as conduct and legal applications go, we're talking about basically what are the legal guidelines for transgender individuals seeking care, and what does that look like if someone wants to seek care. So in Iran, there is an intensive bureaucratic procedure to certify transgender individuals. There's a name change requirement after surgery, so you cannot change your name to better identify with your gender until after you've had surgery, and once you've had surgery, you have to change your name. You can also not socially transition by, for example, wearing clothes that better identify with your gender until after you have been certified as having gender dysphoria. And if you do not have that certification, you can be arrested by the police for cross-dressing. The process can take up to 6 months. Certain individuals are affected more, like those with autism, intellectual, social, or learning disabilities. It can take longer because it's harder to comprehend the intense bureaucracy of the system. Also in the conduct is the problem that professionals don't typically take responsibility for botched surgeries unless there is post-op infection or something really life-threatening to the individual. It's normally just, hey, the surgery didn't go well, we're going to try again, and you have to pay for it. In the US, it's very different. Any adult may change their legal name. There's, of course, no laws against social transitioning. To seek gender affirming care, usually multiple conversations are required with health providers and physicians, but it's a rather quick process that can take 1 to 3 months. So, of course, we have to acknowledge that the laws of the United States are not monolithic. A lot of states have different laws related to gender affirming care. So, this is from the Movement for Advancement Project, a pro LGBTQ organization. So, we have here in the dark green, all the dark green states, it's usually very easy to access gender affirming care and live as a transgender individual. Light green, it's moderately okay. Tan, it could be better. Orange, there's some laws that get in your way if you're transgender, and red is the most difficult it gets in the United States. It's also important to note that though it is also important to note though that most of these laws consider minors, and this policy brief is specifically talking about adults in the United States. And adults in the US are pretty free to do whatever they please. So if Iran were up here, it would be a red or even worse than any of the red states. But it is still important to mention because Iran does have at this point a tradition of gender affirming care. So this is the legal process I was talking about in Iran for getting a new ID card, updating your names, etc. So the transgender individual submits an application. There's a family court branch and a legal medical organization. So the family court is processing all the documents and they're talking with the LMO. The LMO is like the certifiers, the gatekeepers of who's trans and who's not. So when it goes back, there's a permit issued for sex reassignment surgery. The transgender individual undergoes SRS, and they submit proof that they have done so, and the court updates their records. It's much simpler on paper, but the fact that information's technology is not as great as it could be in Iran, as well as the general hysteria towards trans people and the anxiety that targeted trans individuals face, it is much more difficult to go through than it would be in the United States. There's also social pressures which affect health outcomes. Essentially, higher demand for gender affirming care in Iran leads to less availability in healthcare resources. Iran is also an international hub for gender affirming care, so a lot of people in the EU and even many from the United States are advertised to go, and they are adding additional pressures onto the system. There is an additional problem with homosexuals who are not transgender seeking gender affirming care. The rationale behind this is that they seek to avoid persecution. Iran does have the death penalty for homosexuals. It isn't used that often, but does give you a good idea of just how criminalized homosexuality is in Iran. Homosexuals might also believe that they are transgender because of negative social connotations, where basically thinking, I'm a good person at heart, I'm a good person, but I have these feelings, therefore I'm not homosexual, I'm transgender. And those in same-sex relationships will also seek SRS in order to get married. So one individual in a same-sex relationship will go seek SRS so that they can get married to their partner and enjoy the financial benefits from that. We say financial benefits, but really it's more financial necessities for starting a family and cohabitation in whatever context. All this plus a lack of specialists leads to poorer health outcomes in Iran, more risk of box surgeries, less trained in professionals conducting surgery because all the high quality resources are being used up already. So with that in mind, here are some policy recommendations. For Iran, we want to reduce demand so that there is more of the scarce healthcare resources to go around. In addition, we can give the healthcare system a kind of break to innovate over time without constantly needing to deal with patients. So the way that we can do that is first and foremost by decriminalizing homosexuality. This is realistic and it's also unrealistic. It's unrealistic in the sense that there is such a homophobic sentiment in Iran that is also breeded with an anti-Western sentiment. Homosexuality is viewed as a Western thing. Even if that's not true, we can see that a lot of research and understanding of LGBTQ comes from the West. But decriminalizing homosexuality can also be easy in the sense of getting rid of the death penalty, so homosexuals are not seeking gender affirming care to avoid capital punishment. Additionally, we can focus on providing care to Iranians instead of healthcare tourists, as they are called. Basically, we want less citizens of the EU, less Americans, less people from other countries coming to get gender affirming care in Iran because it's soaking up supply and making it harder for Iranians to seek care. On the other side of that, we want to import trans medical specialists into Iran to help teach and train practitioners. This can be done with healthcare diplomacy. For instance, Iran has very close relations with China, who is pumping out specialists who can assist with this. The fourth policy recommendation is to allow individuals to transition without surgery. Basically, lower the standards so that you don't need to get phalloplasty or vaginoplasty to be considered transgender. This will lead to the last policy recommendation, which is to provide options for longer care timelines. Basically, provide the benefits of being recognized as transgender at an earlier time than the care treatment is complete, and just plan in the future to provide care over the course of months or years. So for the United States side of the policy recommendations, we are focused on moving demand from Iran to the United States. We can do this by offering interest-free loans like Iran does, so we can keep Americans in the US seeking gender-affirming care. We can also pay for Europeans to seek care in the United States, subsidize Europeans coming here temporarily to seek gender affirming care. We can also normalize relations and share transmedical research with Iran. So, in this instance, we could be the ones potentially providing transmedical specialists. And finally, it would be interesting to try a system similar to the village positions in Iran, not just for gender affirming care, but in general, practitioners who know their community very well, and there's a basic ratio of many people in a rural constituency per general practitioner. All right, thank you.